Okay. Uh, Good evening, students. I hope all of you have joined in. I hope I'm audible. Okay. So, the topic for today's discussion is surgical aspects of cleft and palate. Um, this is a small topic. All right. Uh, this is essentially a post-graduation based topic. All right. But some questions are still asked, although this topic does not form a major part of the questions that are asked. Your mainstays still remain trauma, TMJ, exodontia, LA, and all of that. But this, uh, there are few questions asked from cleft lip and palate. So I have just concised this topic into some very essential points which are needed for your examination, and what I'm telling you is more than sufficient to help you solve the questions that can be asked in your examination. So let's start the surgical aspects of cleft lip and palate. First of all, we'll see the etiology. All right. So the etiology. Now, etiology is also important. So the etiology is important. It is the most common congenital craniofacial abnormality. Please remember, it is the most common congenital craniofacial abnormality. All right. And it has a multifactorial etiology. That means there are certain environmental factors which are causative of this condition. So they include cigarette smoking, folic acid deficiency, maternal alcohol exposure, teratogenic medicines such as retinoids, corticosteroids, anticonvulsants. Important being phenytoin and valproic acid. All right. These are important: phenytoin and valproic acid. Okay. The next causative factor is consanguineous marriages. All right, that is marriages between close relatives. All right, and maternal diabetes and obesity. Okay. So now coming to the epidemiology of clefts. So if we speak about distribution of oral clefts, cleft lip and palate, the incidence is 46%. All right. Cleft palate is 33%. Cleft lip only, that is isolated cleft lip, this is 21%. All right. Now the incidence of cleft lip with or without cleft palate. All right. So the average birth prevalence is 1 is to 7,000 births. So cleft lip with or without associated cleft palate, the incidence is average birth prevalence of 1 is to 700. It is more common in males. So this is also a question. Unilateral is more common than bilateral. Left is more common than right. And association with other anomalies. So it is 10% associated with other anomalies. All right. Now coming to cleft palate only. The average birth prevalence is 1 is to 2000. Now we are talking about isolated cleft palate. All right. Only cleft palate. So it is more common in females. So cleft lip with or without palate was more common in males. Isolated cleft palates are more common in females. All right. And association with other anomalies is 50 to 60%. Okay. Now there are some common syndromes associated with cleft lip and palate, and we need to know these. So the first one is Wanderwood syndrome, Wanderwood syndrome, Treacher-Collins syndrome, Downs syndrome, orofacial digital syndrome, craniofacial microsomia, and fetal alcohol syndrome. All right. So now half of the syndromic cleft lip palate cases are associated with a triad of micrognathia, glossoptosis, and airway obstruction, which is known as Pierre-Robin syndrome. Alright, Pierre-Robin syndrome. So Pierre-Robin syndrome is also associated with cleft lip and palate, but it is a triad of micrognathia, glossoptosis, and airway obstruction. Now, what is glossoptosis? Glossoptosis is backwardly placed tongue. You may just make a note over here. Backwardly placed tongue is glossoptosis. All right. Also, I would like to highlight over here, Pierre-Robin syndrome is some books use the terminology as Pierre-Robin sequence also. All right. And some books use the terminology Pierre-Robin syndrome. Now, what is the difference between syndrome and sequence? So the triad remains the same. All right, micrognathia, glossoptosis, airway obstruction, and but what some authors are of the opinion that when it is a Pierre-Robin sequence, so what happens is, when what is a sequence? Sequence is something one after the other. All right. So this similarly, if it is a Pierre-Robin sequence, so one thing is leading to other, and other is leading to the next thing. So in sequence, they say that first micrognathia happens, and due to that micrognathia, there is inadequate space for the tongue to be accommodated. Hence, the tongue is backwardly placed. Due to the backwardly placed tongue, due to its constant fallback and blockage of the airway, it leads to chronic airway obstruction. All right. So sequence is in that some things are happening one after the other, and syndrome is when all three are present at the same time. All right. So they are used interchangeably. Now coming to the classification. So a first cleft lip can be unilateral or bilateral. All right. And in unilateral it can be complete and incomplete, and bilateral can be again complete or incomplete. Okay. Now there is another classification known as View's classification, VEAU. All right. So group 1 of View's classification is cleft of soft palate. Group 2 is cleft of hard and soft palate up to incisive foramen. Group 3 is complete unilateral lip and palate. Complete unilateral cleft lip and palate. Alright. And group 4 is complete bilateral cleft lip and palate. This is one of the classification. Now there's another classification, Carnahan and Stark classification. Alright. So this is a pictorial classification. Alright. So he took the incisive foramen as the landmark structure. He took the incisive foramen as landmark structure. So he classified the incisive foramen, so structures anterior to it and structures posterior to it. All right. So he was also of the opinion that structures anterior to the incisive foramen are primary palate, and structures posterior to the foramen are secondary palate. All right. So he gave certain numberings and divided it into sides. So here if you see, I have mentioned the letter R and here is letter L. So this is your right side and this is your left side. All right. All right. So 1 and 4 stand for lip, 2 and 5 stand for alveolus. All right. 3 and 6 for the primary palate, 7 and 8 for the hard palate, and 9 for the soft palate. All right. I'll repeat once again. Carnahan and Stark gave a pictorial classification of cleft lip and palate. Incisive foramen was taken as the landmark. So, especially for the palate, anterior to incisive foramen, he considered it as the primary palate, cleft of the primary palate, and cleft of palate posterior to incisive foramen, he considered it as the secondary palate or cleft of the secondary palate. All right. And in his pictorial representation, he also had side markings. So R stands for right side and L stands for left side. So number 1 and 4 depict cleft of the lip, 2 and 5 depict cleft of the alveolus, 3 and 6 depict primary palate, 7 and 8 depict hard palate, and 9 depicts soft palate. Okay. All right, I am not audible. Let me check the audio. Is it fine now? Please let me know if I'm audible, if the audio is fine. Okay, we now have the Millard modification of Carnahan's striped Y classification. All right, fine. Fine. All right, the audio is fine. The next thing that we have is Millard's modification of Carnahan striped Y classification. See, now for cleft lip and palate, we have various classifications. Various authors have given too many classifications. So I have just given the most important ones to you out here. All right. And the best part would be remember them in a pictorial form, because maybe they give you an image in the exam or they just give you the number. So just try to have a pictorial representation of it in your mind, so that even if they don't give you the picture, they give you a number, you can quickly draw the image in your mind and answer your question. All right, this is how I wanted to tell you that this is how the question can be asked. Now we have something known as Millard's modification of Carnahan's striped Y classification. So what was Millard's modification? He took the nose and the nasal floor also into consideration. All right, he took the nose and the nasal floor also into consideration, and he did not divide it into primary and secondary palate. He considered um, palate anterior to the incisive foramen also as hard palate, and posterior to it also as the hard palate. All right, so here we have this diagram. So the top most of it represents the nose. All right, then 1 and 5 represent your nasal floor, 2 and 6 represent your lip, 3 and 7 represent your alveolus, 4, 8, 9 and 10 all represent your hard palate, but 4 and 8 are the hard palate anterior to the incisive foramen. So this is your incisive foramen. And 9, 10 again represent your hard palate, but the one posterior to the incisive foramen, and 11 represents your soft palate. All right, so these are the few classifications that you need to keep in mind. Now obviously there's a cleft lip and a palate patient, so we have some feeding concerns. Now if there is an isolated cleft lip patient, there won't be much feeding concerns. All right, the feeding concern is only going to be present in a cleft palate patient. Why feeding concerns in a cleft palate patient? Because the palate and the nasal cavity are now communicating. The nasal cavity and the oral cavity are communicating through a cleft in the palate. All right. So what will happen? The child will not be able to form a proper C during suckling of milk. All right. And whatever the child is going to intake, there is going to be nasal regurgitation. Everything the child is going to take is going to go into the nasal cavity. So there are two major issues. And what do we do for it? Now there are specialized nipples and bottles. There are oversized nipples with reservoir space, and there are squeezable bottles to push fluid into the nipple assembly. So what is happening in these oversized nipples with reservoir space? Like now, obviously for such patients you cannot give them a bottle. And which PDF, Bhavna? This session's PDF, I'll make it available. You'll get these notes, don't worry, if you're asking for this session's PDF, Bhavna. Okay, now let's get back here. Now, like for a normal child, when a mother is feeding, there is a bottle and a nipple, and there's constant flow of milk from the bottle to the nipple and to the child. But in this cases, what is happening is we will uh, have to take care. We cannot give the child a continuous feed. So there is a oversized nipple which has a reservoir, and it is attached to a squeezable bottle. So just like a pump, you squeeze the bottle, the milk goes into the reservoir, and from that reservoir it slowly goes, so that the child is able to maintain the pace and there is no regurgitation. All right. And one way valve nipple. So the nipple also has a valve which maintains the amount of milk being delivered to the child. All right, just the names, you don't again need to go into the details. Now this is something very, very important: timing of repair. Okay, now there are certain things. All right, in timing of repair, you have to be particular, especially if there is a cleft lip and a palate child. So care is taken not to do everything at once. Then you have to stage your things. All right, let us see what is the staging and how we go about repairing. Now coming to cleft, first is cleft lip repair, that is after 10 weeks. All right, now cleft palate repair. Cleft palate repair is, please remember, 9 to 18 months. These are the most important ones. These are the most important ones. Okay. Now, there's something known as pharyngeal flap or pharyngoplasty. This is specially done for cleft palate patients who have a nasal twang in their voice. So what does pharyngeal flap or pharyngoplasty do? It does correction of speech. All right. So it is done at 3 to 5 years of age or later, when the speech development is complete. Now, maxillary alveolar reconstruction with bone grafting. Maxillary or alveolar reconstruction with bone grafting is usually 6 to 9 years of age based on dental development. We will be discussing secondary alveolar bone grafting. In that, again, I have another chart in which there are different times and periods for alveolar bone grafting. That also we will discuss. That is also an important table. Now, cleft orthognathic surgery. All right. So what tends to happen is, especially in cleft palate patients, this maxilla tends to become hypoplastic. So these children usually have a class 3 tendency as they grow through their pubertal growth spurts. they have a class 3 tendency because of hypoplastic maxilla. All right, so they will require orthognathic surgery, they will require maxillary advancement, maybe sometimes mandibular setback, to give them a good profile, so cleft orthognathic surgery is done at 14 to 16 years for girls and 16 to 18 years for boys. Okay, now coming to cleft rhinoplasty. What is the need for rhinoplasty? In patients where they have a deformed nose, or they have the nasal uh, bridge area also involved in the cleft, so they will need correction of that also at a later stage. So it can be done after age of 5 years anytime, but it is preferably done at skeletal maturity and after orthognathic surgery. All right, why after skeletal maturity? Because then you don't expect the deformity to relapse due to growth spurts. Now, cleft lip revision. In some patients, they might not have a good scar from cleft lip surgery, so you can do the revision of the cleft lip anytime once initial remodeling and scar maturation is complete. It is best performed after 5 years of age. But the catch is that scar maturation should be complete. Scar maturation should be complete, and it can be done anytime after 5 years of age. Now, please make a point over here. Rules of 10. This is specially for your cleft lip. So the child should be more than 10 weeks. All right, hemoglobin should be more than 10. Weight should be more than 10 pounds. Just a moment. Yeah, weight should be more than 10 pounds. All right, so this is rules of 10 for cleft lip repair. For cleft lip repair, this is rules of 10. This is important. This is also question, your rules of 10. Now we will come to the repair of cleft lip first, followed by cleft palate. But my request to you is, you don't need to go into the details. You people don't need to go into the details of the techniques. You just need to remember the names. Nothing more is going to be asked from here. All right, so first we'll start with cleft lip repair. The surgical correction of cleft lip deformity is known as chilorrhaphy. This is the term used for cleft lip repair, that is chilorrhaphy. All right, so now first we'll see techniques for unilateral cleft lip repair. So I have written them in a sequence wise from the oldest to the newest technique. All right, so Rose technique, first one is Rose technique, then is your Thompson technique, third one is your Blair technique, Le Mesurier technique, Tennyson and Randall technique, that is also known as your triangular flap technique. The next one is Skoog technique. All right, and after that is your Millard's technique, which is also a rotation advancement concept. And the last one is Delaire technique. Alright, these are the techniques for unilateral cleft repair. Now we will see the techniques for bilateral cleft lip repair. Now the first one is a straight line repair or view 3 operation. Alright, the second one is Tennyson's triangular flap technique. Third is Millard's technique. Fourth is Manchester technique. Fifth is Cook technique. Sixth is Black technique, and seventh is Mulliken technique. So all this I have written in sequence from oldest to the newest. Alright, oldest to the newest. Now coming to cleft palate. Cleft palate. So palatography is the term used for surgical correction of cleft palate. Alright, it is usually performed as a single stage procedure, but sometimes it is done in 2 stages where there are extensive clefts, there is an extensive defect. So there you may need to stage your procedure. So in the stage also, the soft palate correction is done first, followed by the hard palate correction. Alright, so let us see. Soft palate closure, that is staphylorrhaphy, is performed first. Alright, soft palate closure is performed first, and hard palate closure, uranorrhaphy, is performed second. Hard palate closure is done second in a stage procedure only. Now coming to the techniques of repair. The techniques of repair. Now techniques for cleft palate repair are different from cleft lip repair, and also unilateral and bilateral cleft palate, there are no separate techniques. The techniques for cleft palate, whether it is unilateral or bilateral, they remain the same. Alright, they remain the same. So again, this is from the oldest to the newest. You all need to just remember the names, nothing more you need to remember. So now I will tell you the techniques one by one. The first one is Wong-Langenbach operation. Alright, the next one is View-Wardell-Kilner operation, which is also known as a VY pushback. This you need to remember, which one is the VY pushback. View-Wardell-Kilner operation. The next one is Furlow's double opposing Z-plasty. This you need to remember, which one is the Z-plasty, which one is the VY pushback. This you just the names. And the last one is Bardash 2 flap palatoplasty. Again, this you need to remember. So the techniques of repair for cleft palate, I'll just repeat again, because you need to remember which one is the Z-plasty, which one is the VY, and which one is the 2 flap, because sometimes in your options they can only give you a VY plasty, Z plasty. So I'm repeating again: Von-Langenbach operation, View-Wardell-Kilner operation, which is your VY pushback, Furlow's double opposing Z-plasty, and Bardash 2 flap palatoplasty. These are your techniques for repair of cleft palate. Now this is important, secondary alveolar bone grafting. There have been questions from here so many times. So we will first look at the objectives or the rationale behind your secondary alveolar bone grafting. Now, why is, first of all, I just wanted to explain you verbally why is secondary alveolar bone grafting done. Now the thing is that when there is a cleft palate which is extending into a cleft alveolus, all right, so what is happening is, due to insufficient bone in the alveolar region. Alright, due to insufficient bone in the alveolar region, you are going to have problems in eruption of teeth. You're going to have issues with the support of your alar bone. So our aim is to restore the sound bone structure so that it can facilitate the eruption of teeth. That is the one of the most foremost objectives, especially in cases of cleft palate which is continuous with a cleft alveolus. Now when we are doing a secondary alveolar bone grafting, we time it accordingly. I have a chart of at what all stages you can do a alveolar bone grafting, and that chart is important. Now we have to time that according to the eruption of the teeth or the mixed dentition phase. Alright, that we'll see later. Now let's come to the objectives or the reason for secondary alveolar bone grafting. The first one is stability of arch. So it prevents collapse of alveolar segments and it improved orthodontic stability. So basically support of the arch. It provides stable alveolar bone for canine and lateral incisors to erupt. So important point, it is providing stable alveolar bone for canine and lateral incisors to erupt. Most importantly the canine, because why? Canine are long rooted teeth, so their roots need bony support. They need bony support so that they can come and erupt in the oral cavity and maintain their position. Alright, supports the ala. Okay, so if you see in cleft lip and palate patients, if you've seen their pictures, you've seen your textbooks, the anatomy around the nose, the nasal bridge, this all area is also distorted. Alright, so and you must have in orthodontics, I do not know if you must have seen chapters on nasoalveolar molding. Alright, so basically you have to mold the ala, give it support and get it into the correct position. So when you have a good alveolar bone graft support, it will help support the ala and give stability to the nose. So support and stability to the nose. Closure of oronasal fistula. So your alveolar bone grafting will also help in closure of oronasal fistula. This is also an important point. And augmentation of alveolar ridge in areas of cleft. That is, augmentation is nothing but restoration of alveolar height. This is meant by augmentation of alveolar ridge. Okay, now coming to the timing of graft. This table is what I was telling is important. Now there are two types of grafting: primary grafting, secondary grafting and late secondary grafting. So I will zoom out. पहली grafting हम कर सकते हैं less than 2 years of age, alright, which is termed as your primary grafting. So this is after lip repair and before palate repair at less than 2 years of age. So more than 2 years of age, it is known as secondary grafting. Alright, this is known as secondary grafting. Now this secondary grafting is further divided. It is further divided depending on the age. So 2 to 5 years is early secondary grafting. 6 to 12 years is your mixed dentition secondary grafting. Alright, your mixed dentition secondary grafting. Now this is important. After central incisor eruption and before canine eruption. There are so many questions after central incisor. The correct answer is, for your, the best time for secondary alveolar bone grafting is between 6 to 12 years. That is after central incisor eruption and before canine eruption. Why before canine eruption? Because by that time we will have good sufficient bony strength to accommodate the canine, to help it erupt, maintain its stability, and accommodate its longer roots. Okay. So again, mixed dentition secondary grafting is further divided into, it was 6 to 12 years. So it can be between 6 to 8 years is early mixed dentition grafting, and between 9 to 12 years is late mixed dentition grafting. Okay. Now, more than 12 years. More than 12 years is late secondary grafting. Now, this one is, please remember, after canine eruption. Your late secondary grafting is after canine eruption. Alright, late secondary grafting is after canine eruption. That is more than 12 years of age. Okay. Now, we are coming to materials used in alveolar bone grafting. Okay. So, there are certain, so I will in detail just talk about the most commonly used bone grafting source, but this is the chart just to give you an idea that what all can be used. Alright, in detail we will just talk about iliac crest because that is important. There are questions from iliac crest and that is the most commonly used worldwide. So now, materials used in alveolar bone grafting, you just need to know the table. Now it is again divided into autogenous, allogenic and alloplastic. So under autogenous we have cranium, iliac crest, mandibular symphysis, proximal tibia and femur. Alright, now amongst this, again, this is most common. Your iliac crest is most common and it gives good results also. Now your allogenic is decalcified freeze-dried bone, osteograft and maxgraft. So these are two brand names of allogenic materials, osteograft and maxgraft. Alright. Under alloplastic we have RHBMP2, which is nothing but your recombinant human bone morphogenic protein. Recombinant human bone morphogenic protein. And TEOM. TEOM, that is tissue engineered osteogenic material. Tissue engineered osteogenic material. And the last one is bioglass. Bioglass under alloplastic. Autogenous, allogenic and alloplastic. These are the materials that can be used. Now coming to our bone grafts. Okay, so when we are using autogenous bone grafts, now the bone graft can be either cortical, cancellous or corticocancellous. Alright, now cortical is where you just take the cortices. Alright, cortices. Cancellous is where you take the soft spongy area of the bone, which is also the marrow area, the cancellous part of the bone. And when you take a corticocancellous bone graft is when you take the cancellous area, that is the soft spongy cancellous marrow area. Along with that, you take the cortex and make chips out of that, small fine chips out of the cortex, and you take the corticocancellous and you just pack it into your cleft area. Alright, so cortical is less vascular and prone to resorption. Alright, so this is actually not suitable for cleft patients because if it gets resorbed, it will not lead to successful eruption of teeth. Alright, now cancellous is a particulate form. Alright, it is easier to pack in the cavity in the cleft area, but it is difficult to stabilize. Alright, वो वहाँ पे टिकेगा नहीं. Cancellous bone is not going to stay over there. This is the drawback of the cancellous bone. So what is the best is your corticocancellous. This is a question also. Corticocancellous. So this adds mechanical strength and it provides good vascularization. So like I just told you, you harvest the cancellous portion, the soft spongy particulate bone. Along with that, you take the cortex, chip the cortex into fine pieces, and then you pack both the corticocancellous portion together inside the cleft. Okay, now coming to iliac crest. Some important questions over here. Site, anterior iliac crest. Please remember, anterior iliac crest. Fine. Now, the advantage, like I told you, it can give you a large quantity of cancellous bone. Plus, it also gives you cortical chips, which aids in osteogenesis. Disadvantage, mild transient gait disturbance. So the patient will have a little walking difficulty because you have taken the bone from the anterior iliac crest. Patient will have difficulty in walking for a few days. Patient will walk with a limp. So there is mild transient gait disturbance due to difficulty in walking. Difficulty in walking, that is meant by mild transient gait disturbance, and due to which there will be extended hospital stay due to this graft. And it is the most preferred or the most common used donor site world over. So 87% of the European surgeons use it, and 83% of North American surgeons use it, and it is most commonly used here in India also. So it is the most commonly used autogenous material for secondary alveolar bone grafting. Alright, so this is all that is required in your cleft lip and palate. I think if you go back and look at the questions, I have covered everything that is asked or that can be asked. So your etiology, syndromes, techniques of repair, your secondary alveolar bone grafting, this is all that is required. We do not require anything more than this. So I'll make sure that the PDF is given to you all so that you can add all of this in your notes. All right. So thank you students and happy studying.